I'll go ahead and get started. Welcome to Smilow Shares with Primary Care. This is a session held collaboratively between our Smilow partners, who are the Yale Cancer Center and the Northeast Medical Group Primary Care, which is part of the Yale New Haven healthcare system. We speak monthly on various topics that overlap the oncology world and the primary care world, the bridges between us, and how to collaborate better. Today's talk is on health equity, and we have an outstanding panel of clinicians and researchers to help us understand better how to best address health equity in cancer screening. We know that this week or this month, the word equity has become a little heavy. And this talk has been planned for months, and we hope that you will find it to be delivered from the heart with reasons that help us to take better care of the patients that we serve. I am going to kick it off. I can't remember. I don't think I introduced myself. I'm Karen Brown. I'm a primary care internist and also medical director of primary care for Northeast Medical Group. And I'll introduce Lou Hart, who is a pediatrician. He's the assistant professor of pediatrics as a hospitalist working here at Yale New Haven Hospital, and the medical director of health equity for the health system. I know him best from his work where we share care signature pathway development, and where he lends his voice to help our pathways be equitable and more informed, also clinically. He leads these efforts across the organization by highlighting and eliminating costly, unwanted, and unnecessary variations in clinical operations and management, which extends beyond the care signature pathways. He studied financial economics, medicine, health, and society and philosophy at Vanderbilt University, and then medical school at the University of California, San Diego. He completed his residency training in pediatrics at NYU, and he was an inaugural clinical leadership fellow in quality and safety at NYC Health and Hospitals. And he's now a Posen Commonwealth Fund Fellows and EMBA 25 candidates at the Yale School of Management. Lou, thank you. And I will turn it over to Ann Chang, who is my Smilow counterpart.
Thanks, Karen. And thanks to everybody for joining. See some of our regulars on. Thank you for joining. This is a real treat tonight. And as Karen said, we planned this ahead of time. So I think it has particular meaning, and it's important to talk about, and we have a really great panel. I have the honor of introducing Dr. Tracy Battaglia, who's Associate Cancer Center Director in Cancer Care Equity for Yale Cancer Center. She's a primary care clinician investigator, internationally recognized for her collaborative and innovative approaches to addressing health disparities among women that have been historically marginalized. She's led the development of foundational infrastructure to support community-engaged methods in translational science, and her own research focuses on engaging with the community to increase access to care for at-risk women, including groundbreaking work on the role of oncology patient navigators. Through her participation through several National Cancer Institute cooperative groups, she contributed to the 2012 Commission on Cancer accreditation standard requiring navigation services in cancer centers, and is founding chair of the National Navigation Roundtable. She partners across sectors for sustainable navigation workforce. We also have Dr. Jackie Gaddy, who's an assistant professor of medicine and deputy director of the Diversity Enhancement Program in Oncology for Yale Cancer Center. Dr. Gaddy is a medical oncologist who cares for patients as part of the Center for Gastrointestinal Cancers at Smilow Cancer Hospital and Yale Cancer Center. And she's really dedicated her career to improving cancer care delivery for Black patients while also addressing the needs of Black, Indigenous, people of color cancer care providers through an educational and investigational approach. Her primary research focus is evaluating how the social determinants of health impact cancer care delivery. We'll be talking about that tonight. And she's a 2012 recipient of the Medical Student Rotation for Underrepresented Populations and a 2019 recipient of the Resident Travel Award for Underrepresented Populations from Conquer Cancer, the ASCO Foundation. And she holds a 2023 ACS IRG Pilot Award for Underrepresented Minorities. So really, really happy to have all of you here today. And I'm going to turn this over to Jackie.
Good evening, everyone. I do appreciate all that are here and all that will listen in the future. Tonight's objectives, which we are very hopeful to accomplish, are to understand the interconnected contributors to cancer inequities and to also understand how those inequities are impacted amongst our patients across the entire continuum of cancer care. And then also, I think, which is the most hopeful goal, is how can we identify actions that we all as providers, as clinicians, can take in order to address social drivers of health to make sure that we are ultimately giving the best care that we can from an equitable standpoint for all of our patients. So that means that we will consider data, that we will discuss navigation tonight, that we will talk about patient care decisions, and also we will end towards the end, I would say, to describe the language that we use and the impact that that actually can have on patients that are generally minoritized.
Uh-oh. There we go. Thank you, Jackie. And I just want to start by saying how humbled and proud I am to be part of this conversation tonight. We are hopeful to engage in a dialogue with one another, but also with all of you on, as Dr. Gaddy sort of pointed out, what are sort of the actionable steps we can take to ensure health equity for our cancer patients across the spectrum of cancer care. I want to just also state that I learned a ton myself personally from just preparing for this conversation tonight. So I want to thank Smilow Shares for inviting us to have this conversation. So I'm just going to start with some foundational sort of grounding for us around cancer disparities or cancer inequities and what's really the problem we're here to discuss tonight. Now, I'm sure this audience is well versed in the notion of disparities in health outcomes. We're going to talk this evening around disparities or inequities in cancer care. And the AACR, the American Association for Cancer Research, is one of the premier cancer organizations that puts out an annual disparities report, which I think is a nice sort of framing for us to have this conversation. We know that cancer death rates have been steadily declining since the 1990s. We have averted millions of deaths, and there are millions of cancer survivors, likely some on this call tonight. And that is because of the reduction in smoking and other health behaviors, but mainly due to improvements in treatment and early detection. And so while that progress is notable and important to celebrate, there are stark inequities in the cancer burden, largely driven by structural and social factors. And so by no means do we want to leave the message that African American or Black patients or populations are the only groups suffering from cancer inequities. But unfortunately, this population has the starkest inequities, and they are persistent. And so this is the original report from the American Cancer Society on the report of poor people with cancer was published in 1986. And what you can see in sort of just this snapshot, it shows all cancer sites for males and females, and it breaks it down into the major cancer, most solid tumors, lung, colon, rectum, and prostate for males and breast for females. And what you notice is that while there may not have been inequities in mortality for these cancers in the past, as treatments and diagnostics and screening went into play, we start to see these inequities, and they persist over time. But by no means do we want to give the message that this is the only population that is suffering from inequities. The AACR report also describes in great detail other US population groups that are experiencing cancer inequities. And while we may not be touching on all of them this evening, and the cases that we chose may not touch on all of these intersectional sort of identities, know that we recognize that these populations all deserve some recognition and further work. So there's many frameworks to help us understand the complexity of cancer disparities. I highlight this because it's actually a snapshot of the 2022 AACR report and their sort of framework for cancer inequities. And so looking to the left of the slide, you notice that there's recognition of structural racism and how structural inequities and social injustices interact, and at the sort of patient level, these social determinants of health affect the ability of populations to access care across the cancer care continuum. On the right of this slide is the 2024 sort of advancement of this model, recognizing that it's not just structural drivers and social drivers, but there's this ancestry-related biology that's impacted by structural and social drivers, that this sort of biopsychosocial model or framework is evolving and our understanding is evolving. And we're going to try to get at some of that in our conversation this evening. But ultimately, we're here because we all want to achieve cancer equity. What do we mean by cancer equity? We want everyone to have an equal opportunity to prevent, find, and get proper treatment for cancer. And we want to make sure that the lack of health equity, we know that the lack of health equity can result in unjust differences that we're going to highlight in our cases this evening. And during our talk, we're going to be coming back to this slide, which is really helping us being introspective about our role as care providers and where are there opportunities to intervene and mitigate inequities. Across the cancer care continuum, we're speaking to our primary care colleagues this evening, and I'm wearing my primary care hat. You know, where are there opportunities from a prevention and early detection diagnosis? And across these cross-cutting areas that as primary care providers, communication and surveillance and decision-making and implementation science and care delivery, where are those opportunities? So hopefully you'll come along with us in sort of keeping this in your mind as we go through the cases. I'm going to pass it back to Dr. Gaddy, and she's going to get us started with a real life case that she has had the opportunity to participate in.
Thank you, Tracy. And I think you have set it up in a way that is exactly what I would say is that when I walk into any of my patients' rooms, regardless of their background, regardless of their race, et cetera, the way that I try to approach all my patients and probably almost everything in life is how can I make sure that the care that I'm about to offer is delivered in an equitable way. And unfortunately, many of the patients, certainly the one that I will present this evening, have suffered various challenges that have ultimately resulted in them not being able to receive inequitable or not being able to receive equitable care. So this patient that I am going to describe is certainly one of my active patients that I see and will probably see actually this week. But this young woman, especially from a cancer standpoint, I would say relatively young, a 52-year-old Black woman, known multiple medical morbidities, some of which include obesity, some of which include underlying heart disease, along with diabetes, et cetera. She initially presented with just having very early onset, early detected colon cancer, and unfortunately recurred within a year and had now metastatic disease. What is really important, besides actually being able to highlight her very short interval recurrence, is the fact that in addition to be able to actually discuss her past medical history, there's high importance of needing to discuss her social drivers of health history. This woman, at the time of me initially meeting her, was unhoused, a term that I strive to use for patients that we normally would consider quote unquote homeless. Unhoused is a little bit more favorable for these said patients. Unemployed, and that's a result of her actually having to leave her job so that she can actually endure the every other week treatments along with the toxicities that would essentially be lifelong for her. At the same time, unfortunately, considering a possible divorce from her husband, and also not having a car, and as a result, no reliable transportation. If we think about all of those said social drivers of health, each of them in their own individual way serve as a barrier for her to possibly not be able to be enrolled into a trial, for her to not be able to show up for said appointments, and ultimately for her not to be able to get equitable care that she certainly deserves. If we go to the next slide, I will further describe what I have already alluded to. So what are the social drivers of health? We are currently in a space of hopefully evolving to, instead of using what was initially referred to as social determinants of health, to social drivers of health. And many will say, well, why are we using that term instead of the other? Well, when we think of the term determinant and just the meaning of that, determinant is almost as if it's a fixed, established thing, as opposed to a driver is there are barriers in place that if we modify and address said drivers, we can ultimately strive to get equitable care. So in time, ASCO and other organizations will certainly transition to using social drivers of health. But what are the social drivers of health? As I have already alluded to with my patient, it's education, it's healthcare and quality, it's neighborhood. So do you live in a neighborhood that has a food desert, that has safe, reliable playgrounds, that has areas that would allow you to exercise, et cetera? What is your background from a social standpoint? Who supports you? Do you have a husband? Do you have a partner? Do you have children? Do you have family? Do you have a church faith background? And then also, as I alluded to with my patient, what is your stability from an economic standpoint? Will you endure further financial toxicity because of the now treatment that you have to endure for possibly lifelong? Other things that I will address within this patient and within the actual presentation are, as we have here, mindful charting. So using terms that are in very much ways racially charged, and also considering structural racism when we think about the care of our patient. And ultimately, what Tracy will certainly discuss from an expert standpoint is navigation and the benefit that it provides to our patient. And I think, as Tracy alluded to earlier, when we continue to show this slide, it is for us to all think, us as presenters, and also certainly for all of those in the audience, is how can we think about our patients and consider their targetable solutions that we can ultimately get to giving the best care for all from an equitable standpoint.
Thank you for that. I can't help but pause and sort of think about this particular case. You didn't give us many details about her kind of diagnosis, but this was a recurrence. And I would say 52 is pretty young. But what, thinking about moving upstream, right? And sort of
Right.
screening and the prevention. Now, obviously, by the time this patient gets to you, it's a little bit too late for you to intervene anywhere, but any sort of thoughts on sort of messages to our primary care physicians who are listening around the role that they could potentially play such that a patient like that gets to you sooner?
Absolutely. And I'm glad you brought that to the forefront of my mind. So what would be upstream targets? When we think about colon cancer in particular, which is certainly a cancer that I regularly treat, probably about 1/3 of my patients at least, and majority of them being Black patients, considering when we think about the demographics, unfortunately, of colon cancer. In recent years, the colon cancer screening recommendations that previously were 50 years old have transitioned to 45. And this patient is actually a great example of why that is necessary. Especially Black patients have now been found to present at earlier ages and also present with more advanced stage when they present. So what can a primary care doctor do? I think when I was in training, I often would hear my patients say, well, I did discuss this with my primary care doctor. And I think there is a disconnect oftentimes, but I think hearing red flags to think about if a patient is saying, I'm having bright red blood, correct them. Or I think even more upstream, a patient is now approaching their 45th birthday. It's about 6 months away. We know they're going to need screening. Can we assure and ensure that that said patient will have a gastroenterologist that can either do a colonoscopy or we will assure that there are other screening modalities such as Cologuard and other testings. I prefer colonoscopy, but I do understand there are certainly a lot of barriers for colonoscopy, such as having to take off that day of work to have a reliable driver and possibly miss additional days of work. But ultimately, really just driving forth the need to have timely screening, making sure that the results of the screening, the pathology, is followed up. So that way, if in fact, unfortunately, like my patient, they have cancer, that they then are matched with an appropriate oncologist for their new cancer diagnosis.
Thank you for that. I'm going to move us along to the next case, unless any Dr. Hart or Dr. Gaddy have any other comments about this case.
Just curious, Dr. Gaddy, and to you as well, Dr. Battaglia, like as there's an evolving science and an evolving understanding of the role of diet in driving colon cancer, and we know of where you live is often where you shop or have access to fresh produce versus having access to frozen, calorically dense foods that might be pro-inflammatory, that might be high in omega-6s. Like, I'm curious if you can speak to a little bit of that and the role in primary care of really talking about like the diet, the foods you eat really are medicines and they can drive your risk for cancer. And how might we be able to come up with a diet as a part of your treatment plan that's realistic based on what you have access to? You know, how might that be also an upstream intervention way before a patient even develops cancer?
Absolutely. And so thank you so much, Dr. Hart, for mentioning that. What I alluded to earlier was the fact that we are now seeing early onset cancers, especially for Black patients. And why is that? Because there's this connection that, as you just said, patients of color, especially Black patients, are found to live in areas that have food deserts, that do not allow them to have reliable grocery stores, that oftentimes have areas that do not have reliable transportation, whether that be busing, et cetera. But even if we just take away Black patients, this is also true for Hispanic patients and marginalized patients from rural communities, white, et cetera. And we don't actually have enough data, Dr. Hart, to certainly say for sure that this is diet induced. We do think that there's a possibility, and we're hoping to kind of explore that further. But I think from a primary care standpoint, we always say everything in moderation, right? So if there are patients that are relying on fast food, are there healthy options from that said fast food restaurants? Okay, maybe you don't get the fried, maybe you get the grilled chicken option, maybe you don't get the bread, because what is most important, especially from an equity standpoint, is you really have to meet your patients where they are. If they live in a food desert, how can you make sure that the options that are available in a food desert, whether it be the local corner store, et cetera, that they are encouraged to pick items that are not filled with high foods that will often lead to cancer, such as a lot of red meat or fatty foods and things that are processed, et cetera. These are things that I certainly think from a primary care standpoint, we can be discussing with our patients. So thank you so much, Dr. Hart, for that question.
And the FDA report, right, that just came out about the relationship of alcohol and cancer, really profound stuff. I've talked with some of my colleagues about that. They're like, I don't believe it. It's too strong, especially with the breast cancer sort of relationship, like 1 drink a week versus 2 drinks a week and the impact that has on incidence. So it's another counseling opportunity in primary care.
I agree with that, Dr. Battaglia. And I think that's why the social drivers of health assessment is so important, because if we're asking our patients, are you drinking? How much are you drinking? Is that daily? What are you drinking, et cetera? Then we can kind of learn what interventions are needed for them.
Okay, I'm going to move us along to the second case, which actually is my case. And I can't get these slides to cooperate with me, so sorry. Okay, so since it's my case, I take the liberty of actually presenting 2 cases. And some of you who know me have heard me present this case before, because they're not new. These cases are actually from 2018. I'm new to the Yale Cancer Center and the Connecticut community. I practiced in Boston for 30 plus years as a primary care physician and as a breast health specialist. And this was 2 cases the same week at Boston Medical Center in 2018. after spending 25 years focused on care equity interventions to prevent things like this. This was what I faced in my care. The first is a 48-year-old white married physician scientist who felt a right breast lump. She did have a history of stage 4 Hodgkin's lymphoma, did not receive radiation, so was not considered to be high risk for breast. Regardless, she was compliant with her mammography screening and had had one 18 months prior, considered in a kind of average risk group. Her symptoms began 24 hours ago. She felt a 1 centimeter palpable lump. As a physician scientist with privilege in that institution, she had a same-day mammogram, ultrasound, and biopsy, almost unheard of in our health system, and was diagnosed within that week with a stage 1 ER/PR negative, HER2 positive invasive ductal cancer, which is a fairly aggressive tumor, but still stage 1. That same week, my patient was a 42-year-old Black unemployed single mom who also felt a right breast lump. She had a history of preeclampsia and untreated hypertension. She had no prior mammography screening. Her symptoms started a year ago. She presented for care several times over the course of that year, and she disclosed challenges in accessing care because of a house fire that left her unhoused and in a shelter as a single mom of a newborn child. She lost her insurance after her baby was born, and the records indicated that she was lost to follow-up. When she presented, she had a 10 centimeter palpable lump. We worked really hard to get her diagnostic imaging that week. She presented for that diagnostic imaging, but they turned her away because she brought her infant child with her, and they could not do the imaging with that baby there. So it took her another 6 months to get back in to get that imaging, and was ultimately diagnosed with a stage 3 cancer. And so these figures sort of highlight the different paths these patients took. And I will say, you know, all of us on this call are likely touched by cancer personally and professionally in different ways. The left case is me, actually. That was my experience with my cancer diagnosis, and the patient on the right was my patient that I was caring for. And, you know, really just stark differences in our experiences that I find, frankly, unacceptable. And so we're going to go through this exercise again and asking ourselves, where are the opportunities, or where were the opportunities for us to intervene and to mitigate what I just sort of highlighted for you. So the first theme is really around sort of data. Like, we have data. We need to leverage our data, especially in our catchment, in our practices, in our population, to understand who's getting care and who's not getting care. So this is SEER data. This is a slide that looks very familiar to all of you because it hasn't changed in decades, right? So this is breast cancer mortality differences between Black and white women, which we fully acknowledge is a proxy for other sort of measures of sort of risk. And you can see again, as I highlighted, the inequities started in the early 80s when we started screening for breast cancer, and they've persisted over time despite the amazing advancements we've made in diagnoses and treatment for breast cancer. Well, we have our own health data here, and I'm going to turn it over to Dr. Hart so he can walk us through data that he and his group have had the opportunity to really understand, to help us better understand how we can care for our cancer patients here.
Thank you so much, Dr. Battaglia, and thank you all for having me. I think the point you raise is so important, that these are not fixed differences or fixed inequities that have to persist going forward. We often look at them retrospectively and identify disparities, which is just another word for difference. We're calling them inequities because we believe these differences are unjust, they're socially mediated, and that we can do something about it with the proper interventions. And really what we're learning, looking at our data, a lot of this comes to access, and I think what was described as privilege, but really the resources that one accumulates in their life from an early age, and how they're able to navigate the use of said resources and connect the dots. That is, navigating being a person in America or in Connecticut, and navigating being a patient in our very complex healthcare system. So Vizient is a data aggregator. They're almost like a data consultant company where we have the privilege of sending our data to Vizient so that they can kind of analyze our data, benchmark it against other health systems to let us know how we're doing across core quality and safety measures, and really better understand where our vulnerabilities, or as I prefer to call them, opportunities are to improve our care, to improve access, transitions, outcomes, and addressing social drivers of health. So when we look at our Vizient data, and this holds true nationally, and we can actually break it down to each of our delivery network hospitals. We'll focus a little on Yale New Haven Hospital in the New Haven catchment area, but it's important to understand that where our patients live, absolutely, sadly, even in 2025, predicts their likelihood of having access to high quality screening, of having access to diagnostics, and of having access to the prevention of metastatic cancer. So when we look at patients living in what is defined as vulnerable communities by Vizient, and Vizient really defines 9 domains of vulnerability, these take into account factors like access to healthcare, education, income, whether the neighborhood conditions, access to parks, access to grocery stores, as opposed to liquor stores and bodegas. So it's important, it takes into account 9 kind of domains. You might be familiar with area deprivation indexes, where the CDC has a social vulnerability index. Vizient actually created their own, the Vizient Vulnerability Index, but this is purely from healthcare data, as opposed to the SVI from the CDC is based on national disaster response. And the ADI, or Area Deprivation Index, is kind of based on 30-day readmissions. So it's a little bit different, and this is changing over time. It gets reweighted over time to really be the most reflective of clinical conditions and risks. So when we look at our patients who live in vulnerable neighborhoods, they are the least likely to be diagnosed with breast cancer. It's not like it's protective. So what does that look like? Next click, please. This shows you as a patient's community, or their zip code is how this is defined, as that rises in vulnerability in terms of probably underinvestment, chronic divestiture from certain parts of our city here in New Haven and certain parts of our state, we see that their risk of or their potential to be diagnosed with breast cancer goes down. And that should be head scratching. If breast cancer is an equal opportunity victimizer, if this is an equal opportunity, I can't think of a better word, we are all at equal risk potentially for having breast cancer, and maybe some more. Why would living in a vulnerable community be quote unquote protective? That's what the data shows, that patients living in low income or highly vulnerable communities, which again is probably not the best terminology because it's a very deficit based approach to understanding community, but this is how Vizient describes it. They are less likely to be diagnosed. Does that mean that they have less breast cancer or they have less access to diagnostics? Next click, please. When we're again looking at patients living in vulnerable zip codes here in New Haven, we see that they're less likely to be screened for breast cancer. Next click. And again, the data shows a very compelling trend line that as vulnerability of your zip code rises, your access to screening or your utilization of screening, I prefer the term access, goes down as well. So again, a very compelling story that tells us that there are less breast cancer cases being diagnosed because we're screening less. There's less access for certain patients living in certain communities.
I'll point out, Dr. Hart, these rates are low in general.
This is national data because our domain here in New Haven shows it's actually much higher, and
Okay.
it actually shows a little bit of, it's not a perfect line like this because it shows the same directionality in terms of the trend, but because it requires a certain amount of patients from each zip code to be able to be included in this
Gotcha.
analysis, it's a little bit of a choppier line. But if you could put the plots into a trend line, it would show the exact same story. But to your point, it's very sad that as a nation, we perform so poorly given the vast amount of resources we have. And then finally, those who are living in these potentially more vulnerable communities are more likely, if they have breast cancer, to be diagnosed with metastatic cancer, to be diagnosed with a secondary form of cancer. Just again, speaking to the point, less access, less diagnostic. When it is diagnosed, it tends to be much more advanced and might have even spread. And again, the data is very compelling. Our data looks identical here locally as it does across the nation. And the next click, these are the 3 key domains in which, next click, Dr. Battaglia, please. These are the 3 key domains in which this shows up. These areas of vulnerability, as Vizient describes them, economic, around poverty, unemployment, lower median income. These are things that should be kind of triggering as you're understanding your patient and their journey, their risks for cancer, which you might, breast cancer in this example, which might not be readily apparent, that connection, but there absolutely is a connection. Around education, whether your patient has completed college or whether they were able to get their high school degree or whether they have access to preschools in their community. These are the things that very indirectly absolutely predict risk of metastatic cancer, which I don't think many of us were taught in medical school. And then the access to healthcare. Thankfully, in our state And in our catchment area, compared to other parts of the country, there's a lot more access. But even when you start to break it down, which we'll do in a second, even when you get to live in a relatively affluent state like Connecticut, there are still stark differences based on where you live in terms of your access to care. The data is compelling, and it's time for us to do something about this. I think the next slide, I'd like to kick back to you, Dr. Battaglia.
Yeah, thank you. It's actually really interesting to hear you sort of say, like, as you're doing your history and you're learning about your patient, like those kinds of things that you're learning should be triggering for you in thinking about cancer screening and diagnosis and all those things. And I don't know that I have really thought about it that way. So thank you for that. This is data from the BRFSS survey data, which is, national survey. The most recent data is 2022. The point of this slide is to demonstrate cancer mammography screening rates across the country. And Connecticut is in blue, which means we're doing really well. And we're, I think, always in like the top 5 sort of states for this, patient-reported data on mammography screening. And so there's often this sort of notion that we have no inequity in cancer screening rates. Well, actually, I would say look at your data, because if you go deeper, this is the state of Connecticut and breaks it down by county. And so there are differences here, right? So I think this is New Haven. You got to help me with the counties because I'm new to Connecticut. I think New Haven and Windham are the 2 counties that, we're not doing where we need to be doing. And this is where we are, New Haven, Smilow, and, the health system. Like, this is our hub. Like, we can do better than this. So I just challenge all of us to ask for this data for our populations, for our patients. We need this knowledge to sort of advocate for resources to support our patients. So I'm going to transition us to sort of thinking about cancer screening in general. And I can't talk about this topic without sort of talking about mammography screening and guidelines. One of the last things I did before I left Boston was to get the health system to change their mammography screening guidelines from 50 and above to 40 and above. Most of our patients that I was caring for were non-white patients and had higher stages of cancer, yet we were using guidelines that was from data that represented mostly white women. And so the 2016 guidelines from the United States Preventive Services Task Force was, as we all know, 40 to 50 was a C recommendation. That doesn't mean it's not recommended. It's just not necessarily paid for, and it's requires sort of shared decision making. But I think many of us sort of interpreted that as it's not recommended, and it didn't make it to most of our dashboards. In 2023, the American College of Radiology was the first professional organization to come out and sort of publicly say that we need to be thinking about racial inequity when we think about cancer screening, and specifically made the recommendation that breast cancer risk assessment should happen by the age of 25 to help you figure out who should get screened and if they're average or high risk cancer patients. And so we're going to get to that point in a minute, but in 2024, the United States Preventive Services Task Force changed their guidelines and changed the 40 to 50 to a B recommendation. And so I just want to take a moment to sort of highlight like what the background was behind that change. There was not necessarily a lot of new data, right? There was some more modeling data that we looked at, but the core of the data didn't change. But what did change was that there's an increased incidence rate of invasive cancer for women in their 40s. With an average of 2% annual increase between 2015 and 2019. And this slide sort of just astounds me every time I look at it, because if there's an increase in incidence in younger women, who are those women? This is data from SEER. This is old, it's from 2018, but what it demonstrates is this is the incidence of basically the peak age of cancer diagnosis, breast cancer diagnosis for white women in the dark boxes, and in the lighter colors, Black, Hispanic, and Asian. The peak incidence in non-white patients is in their 40s. The peak incidence for white patients is in their 60s. So of course, we may be sort of inadvertently disadvantaging those populations when we take guidelines and apply them for all. And so I think it's just important for us to understand a little bit the data behind these recommendations and sort of the importance of race as a risk factor for incidence and recommendations for screening. I want to acknowledge that we also use decision tools to support us in making decisions about risk and appropriate screening opportunities for our patients. And so I'm going to pass it back to Dr. Hart, who's going to talk to us about cautionary sort of tales around the misuse of race in some of these decision support tools.
Thank you so much. I think it's such a nuanced conversation and topic, and I'll try to do it justice here in a couple of minutes, because there's really kind of two schools and now a third school of thought on this, is that if race is a driving factor, we should use it deterministically in decision support. It should be used as an absolute categorization of risk. If a patient identifies as that race, we should put them into quote unquote that bucket and say they have the same risk as everybody else who's in that category. There's another school of thought that says like, well, there's probably a whole lot more nuance there, and we really don't want to kind of judge a book by its cover. We don't want to treat all people the same based on their skin color. So there's no place for the utilization of race in clinical decision support. So kind of race-based or race-neutral, race-blind, you would say. And then there's this growing kind of third thought where it's like, we need to be conscious of what race is associated with and how race might act as a social risk factor for certain experiences like chronic discrimination, like undereducation because of where you were forced to live, or where your grandparents were forced to live because of programs like redlining. So it's important to kind of think about this holistically. So we're going to talk a little bit about race and clinical prediction tools and how oftentimes we apply the kind of very binary approach of race-based or completely race-blind. And I think we have to take this into careful consideration because there are real consequences of doing both approaches, and we should at least be informing our patients when this is happening. Now, not only is it the right clinical thing to do to improve quality and safety of care, but it's actually a federal law. In the prior administration, in May of last year, there was a revision that Health and Human Services made to the Affordable Care Act that bars the use of input variables like race, color, national origin, age, sex, or disability to be utilized in patient care decision support tools that can create discriminatory care, discriminate on access on the basis of those federally protected identities. The compliance date is May 1st. Again, we shouldn't be driven to this work because of compliance, because of regulatory requirements. This is the right work for us to be doing as those who are dedicated to advancing quality and safety in healthcare. But here's a real important understanding that there are real legal consequences for systems that don't address this work. And thankfully, Yale New Haven Health is really the tip of the spear in this work and have been long underway over a few years now. Next click, please. The real takeaway from this slide is what we are doing in utilizing our care signature program, which I'll describe in a second, is really trying to identify which clinical algorithms, which clinical guidelines, which clinical risk calculators take into account race and predict different clinical risk or recommend different treatment and management options to clinicians. And how might this be happening in the background in Epic without the clinician understanding that on the basis of a social identity, risk is being applied to their patient that they might not even know and might not fully reflect the underlying risk that unique patient has because they're kind of being dumped into a larger population and having that population's risk onto them when it comes to race, age, sex, or disability, and how we might be able to mitigate that risk through either substitution to a new tool that is more accurate, that does not take into account race, how we might be able to eliminate the use of the tool. It's not a tool that we really believe in. We should not be using it at our health system, or how we might be able to mitigate that risk by making sure that our patients are aware that racial adjustment occurred in a clinical prediction tool that we utilized, and how we have to admit that there are limitations of these racial adjustments, that they are far from perfect. Race is a social category. It's very fluid over time and does not represent all categories. And there's 7 federal options that cannot represent all of the diversity that exists in our nation or in our state. And it's important to understand how, through a shared conversation, we can engage our patients after informing them of the practice in a shared decision-making model. Next click, please. And this is where I'll take it to you, Dr. Battaglia, to kind of show us an example.
So thanks, Dr. Hart. So many of you on this call may be familiar with the breast cancer risk assessment tool, sometimes called BCRAT. I think I messed up the acronym there. That's a typo on my part. It's also known as the modified Gale model. You can access it through the NCI website. It's pretty easy to use, and it is a highly sort of recommended tool to assess our patient's risk for breast cancer. And so if we go back to the case and we look at the 42-year-old patient that I presented to you, and put in these sort of parameters of her age of first period, her first live birth, her history of 2 benign biopsies, and 1 first-degree relative with breast cancer. If we change only one thing, and that is her race from white to black, look at the differences in the output. So on the left is everything the same with white race, and on the right is everything the same with black race. I also practice high-risk breast, and in my practice, I counsel women all the time about risk reduction strategies, which are determined by your 5-year risk and your lifetime risk. If your 5-year risk is over 3%, it is appropriate to speak about chemo prevention medications for risk reduction. If I treated this patient as a white patient, I'm sorry, black is on the left, white is on the right. If I treated her as a white patient, she would be eligible. If I treated her as a black patient, she would not be eligible. Same for lifetime risk, which dictates whether or not patients are eligible for supplemental screening using MRI. Greater than 20 to 25% eligible for MRI, less than that, not eligible. So this could have a profound impact in what recommendations we're giving around risk reduction and screening. And so there are other tools that we can use, and we are very fortunate to be in the Yale Health System that has the signature care pathways. And Dr. Hart has been influential in guiding us in these signature care pathways, how to address this in our care pathways. So Dr. Hart, you want to take this?
Well, none of this work happens on an island or alone. It wouldn't be without the support of, Dr. Brown, Dr. Battaglia. Here I'm highlighting Kate Mason's leadership of our clinical consensus group. I think you raised a really important point there. And we kind of looked at some slides earlier that showed that like African Americans compared to white patients are more likely to develop their cancers earlier. They're more likely to have worse outcomes when they do develop cancers. They're more likely to present with metastatic cancer, often linked to where they live. And yet the calculator predicts lower risk for African American women compared to white women in regards to breast cancer. So is that a really good use of race as an indication, or is that the best use of following the epidemiological data when it's a whole lot more nuanced than just that? So this is an example of how when these decisions are happening in the background, a clinician is blindly entering information into the calculator, not knowing that it's going to predict vastly different risk of what seems to be an innocent category like race, and how that actually would influence the downstream management of availability for different diagnostics and therapeutics earlier in the course of illness. So again, this has a real lasting impact on our patients. So here, what we're trying to highlight is that when tools that use race in clinical prediction of risk or in clinical management, we're now going to be including these kind of racial adjustment caveats, and they're going to inform our clinicians that, racial and ethnic categories do not reflect biology. They're not representative of all groups. To promote transparency, we want to inform our patients when racial adjustment is used. We want to admit and be forthcoming around the limitations of racial adjustment in these tools, though they often represent the quote unquote best tools we have in medicine, but that doesn't mean that they are perfect at the individual level. And so we need to engage in that shared decision making and then be very transparent around, hey, this Gale 2 model predicts lower risk for African American, Asian American, and Hispanic across the board compared to white women if they have the same variables in terms of other risk factors, so that our patients and our clinicians understand that. And for the Tyrer-Cuzick, for women who identify as Ashkenazi Jewish or have Ashkenazi Jewish heritage, they'll be predicted to have higher risk. We don't just want to enter demographics into fields thinking that it's just used for research purposes or benign, because it actually drives EPIC and other clinical decision support tools to drive different risk prediction. So it has real consequences, and it's important that people are aware of these consequences.
Yeah, I think the other point is because I fill out these risk assessment tools all the time, is not just entering it, talking to the patient and telling them what I'm entering and asking them how they identify themselves, because my assessment is not always right, often wrong. And then even tweaking it and doing it with unknown race to sort of see what the numbers show us and see what our options are. So I'm just going to push us through here. So I could talk with you for an hour about oncology patient navigation. I'm a little biased, but I will tell you that there is no stronger scientific evidence base for an intervention that has been shown to mitigate cancer care delivery inequities other than patient navigation. This is a systematic review, a figure from a systematic review of systematic reviews that demonstrates the impact of navigation on care delivery and equitable care delivery. from early detection and screening to diagnosis and into treatment. And actually the strongest evidence is in the cancer screening and sort of diagnostic follow-up realm. And while it may be outside of your scope as an individual provider, you have influence in your practices to support and advocate for patient navigation systems to support your patients. So, this is a definition of oncology navigation. It isn't evidence-based. I often say if it were a little blue pill, it would be on everybody's formulary. There are essential elements of navigation. One of them, our health system does very well, which is systematically assessing individualized psychosocial barriers to care. And we're very fortunate to have the SDOH screening rolled out across our health system. This is a summary of the questions that are asked of our patients. This is a quick snapshot of a little bit old sort of report of how we're doing. I understand that we're doing better than 1 in 5 now. I think we're doing closer to 1 in 3 ambulatory patients are currently being screened for their needs, their health-related social needs. And about 10 or 11% have a positive finding. And so I would encourage you to, as a provider, be looking at the flow sheets with these results so that you understand how your patients are responding and helping them access resources to support them if they do screen positive. We have tools like Unite Us within our system that sort of supports the patient, even if we don't have a referral or access to a community health worker or a navigator. There are at least these electronic tools that can be shared with the patient. And we have a signature care pathway. Dr. Hart, I don't know if you want to comment on this one.
Yeah, just briefly, that these things are dynamic. So as you're working with your patient, you can start to actually check off these things around whether their annual SDOH assessment was done, if they're qualifying for palliative care, so that multiple providers across encounters can actually be tracking the same patient to not duplicate tasks that have already been done. But I just think it's so important to understand that these SDOH elements or these SDOH risk factors are driving clinical risk. And for the longest time, they've been under-recognized and underappreciated, and we've kind of just dumped them into other categories. But we really need to appreciate these things, not just as social work responsibility or someone else's job, but understand how they impact our patients and how they increase bad outcomes, or the likelihood of bad outcomes. So the idea of intervening upstream and catching these things way earlier in the disease course is just so important. So we have a lot of support that exists in EPIC and that exists in our care signature pathway.
Thank you. So I'm going to pass it back to Dr. Gaddy to sort of kind of walk us through sort of the final sort of area where I feel like we can all learn and intervene and sort of hold ourselves accountable. I know I always have to sort of be thoughtful about how words matter. And I know in this particular case that I presented to you, I contributed to some stigmatizing language for the patient that I shared with you. And I want to learn from that. So Dr. Gaddy.
Absolutely. And thank you both for us all being able to contribute in a way that we are hopefully advancing equity for all of our patients. When we think about, I want to also think about the time, so I will try to wrap this up as quickly as possible to allow for questions if there are any questions. But oftentimes, and a lot of this data that I will present is anecdotal, just from my own personal experience and my lived experience as a trainee and now as an attending in this faculty position. What we have learned and what we have seen oftentimes is that when a patient is labeled as non-compliant or lost the follow-up, et cetera, but especially non-compliant, what I have actually learned is when I see non-compliant in the chart, it actually is a trigger for me. And what I do is I make sure I make note of addressing said non-compliance. So if it was carried forward, which we often do, especially in the era of EMR, I then ask the patient, "You missed your last appointment. Can you tell me a little bit more about why that happened?" Because then I'm giving them an opportunity to actually give me facts regarding their social drivers of health. And oftentimes when I ask that question, not all the time, but again, anecdotal experience, but maybe I should make sure there's some data with this as well, they will say to me, "Well, actually, I didn't have any babysitters available for my actual child," or "I missed the bus and I actually have to take 3 buses to get here." This is when I lived in North Carolina. Or "I didn't pick up that medication because I had to decide if I was going to either take the medication or pay for my child's food that she needed for her lunch tomorrow," et cetera, et cetera. I don't think that that would then be considered non-compliant. I would think that there are barriers in place structurally, likely structural racism, et cetera, that have led to the patient not being able to receive equitable care. So I always try to think about using that language. Sometimes it's certainly like applicable and appropriate, but I think before we put that in the chart, we just need to confirm whether or not it's non-compliant or barriers that they're facing. And again, this is what I've summarized, hopefully rather quickly, but essentially saying that these, like, choice of language or diction, it really kind of, to Dr. Hart's point, and also to you, Dr. Battaglia, it really matters. And there's actual outcomes that result in the language that we choose. We know that our notes are read by other providers. We know that it's copy forwarded in this era, et cetera. So I always try to be very mindful with the words that I use, whether it's in EMR or just in general, because it really impacts patient care. Difficult, angry, aggressive, et cetera, like those same different terms that are used
I've
for
certainly
patients.
used them.
Yeah, and honestly, like even me, I have to be very vulnerable. I agree, Dr. Battaglia. I've used them because maybe said patient was upset because something happened prior to getting to the appointment, and now they're more angry because they have cancer and they're mad at their diagnosis, et cetera. So I think even me, like, I'm certainly not saying that I'm perfect in this. I have my own implicit biases, as we all do, but I think we all kind of need to work together to try to hopefully improve this language to limit said language within the EMR.
Profound, this study, really. So wrap us up, Dr. Gaddy.
Absolutely. So when I think about all of the things that we have discussed tonight, Dr. Hart, Dr. Battaglia, I want to really thank both of you for bringing this information to our primary care doctors and our audience overall. What can we take away? Like, if we leave and we go to see our patients tomorrow, number one, think about the data. We presented data here to talk about various patient populations, especially Black and marginalized patients that unfortunately have poor outcomes. Think about the different tools, especially that Dr. Hart and Dr. Battaglia have both presented, to see if that can enhance screening and overall improve outcomes and earlier diagnosis. Think about drivers as opposed to determinants, taking a full social drivers of health assessment to make sure you fully understand the patient as a whole, not just their past medical history, because actually there's data to show that their social history or their social drivers of health history has greater impact on their outcomes than their actual past medical history. And then also think about the services that are available. We are very much, and I'm very proud to partner with Dr. Battaglia in this space, hoping to improve patient navigation here at Yale and honestly across the nation. It's certainly not just a Yale challenge, it's a global challenge that we are hoping to implement. And then lastly, words matter. Words matter in EMR, words matter when we're in the elevator, words matter, et cetera, et cetera. So just thinking about how that can ultimately impact patient care. And lastly, I think and I hope that this talk really strives all of us to make sure that we are advancing equitable care for all of our patients. And I really want to thank all of you for this opportunity.
And I want to thank each of you for just profoundly well-stated points that were all relevant and things that we can think about and apply to our care immediately. This was a real thought-provoking talk. I certainly really appreciate it. Our time has run short for questions. I think on behalf of our speakers, I will volunteer if there are any who do have a question that we would stay on a few extra minutes. But at the same time, we'll have Renee go ahead and there's a slide on how to get CME for this, which you should have gotten just by being here. But we can show that and feel free to drop off if you don't have questions. But thank you to each of our speakers.
You want me to share that? Am I supposed to share that?
Yes, the last slide.
The last slide, if you could.
And then to our attendees, if you can do the survey once it closes, that way you can get the CME credit. And that's the upcoming events right there on pancreatic cysts and cancer and breast cancer screening.
Thank you so much.
Thank
Okay.
you. I learned so much. Thank you, all
Yeah,
three of
me
you.
too.
Really thoughtful. And I think we need more of that right now. So thank you so much.
Good. And seeing no questions, we'll draw it to a close. Good night, everyone.
Good night. Thank
night.
Good
you.
evening.